day everyone, my name is Konstantin Krychtiuk from the Medical University of Vienna and member of the Young Acker group of the ESC. And I'm standing here at the ESC conference in London, UK with Dr. Will Roberts, an interventional cardiologist from Worcester, UK, who presented some very interesting data on transradial PCI derived from registry data. So, Dr. Roberts, could you please summarize your main findings in a few sentences for our viewers?
Sure, thank you. So our data follows on from the Mortal study in 2008, and we're looking at the differences between transradial and transfemoral access in terms of bleeding and mortality. So to do this, we've taken data from 3 registries in the provinces of British Columbia in Canada and linked those 3 databases together. One is a very well validated registry of PCI procedures and the patient factors. The second is a transfusion registry, and we're using 10-day transfusion as a surrogate marker for safety and bleeding. And we're also looking at the provincial database on death to look at 30-day mortality. We looked at over 80,000 procedures over a 13-year period. And we saw that over that time period, across all indications, radial access became more common. That's STEMIs, that's stable angina, non-STEMIs. And when we performed a logistic regression model, we showed that the transradial route had a lower risk of 10-day transfusion and also a lower risk of 30-day mortality compared with the non-transradial group.
That's very interesting, thank you. If we bear in mind the results of some randomized clinical trials, such as the Radial trial, did you see any differences in bleeding between stable patients and ACS patients, and even a difference between NSTEMI and STEMI probably?
In the study that we present today, we didn't split up by those cohorts. We didn't look at that subgroup. But it's, to me, a slightly moot point. Looking at the Radial study, looking at other registry work, we've seen that there seems to be a risk benefit in terms of bleeding and potentially a risk benefit for mortality in STEMI patients. And if you're trying to undertake radial PCI routinely for STEMI patients, what you really need to be doing is being slick and efficient doing that. And to do that, you really need to be a default radial operator, I would think. And that means that you need to be undertaking transradial PCI for the majority of your cases, be it stable, unstable, etc. We have never really seen any risk, negative risk for transradial PCI. In the past we talked about stroke risk, that was often talked about, but a lot of data, including from Radial et al. In the UK, looking at 430,000 PCI procedures, show that risk we can now really forget about. There's no significant risk of stroke.
So in a high volume transradial center such as yours, do you see any indication for primary transfemoral access, such as cardiogenic shock, for example?
Well, in my work, I'm 94% radial. My centre that I'm in, Worcester now, is about 90% or higher radial. And there are very few cases now where if you have the appropriate equipment and skills where you need to go for a femoral first approach. We have sheathless guides. You can actually use 8 French guides sheathless, which is the same diameter as a 6 French sheath. And we have lots of techniques now with balloon-assisted tracking, with the use of guide liners, that allow us to undertake a lot of these procedures from the radial route. In my experience, if the patient has cardiogenic shock, if I can feel a pulse, I will still undertake the procedure from the radial artery. And that gives me the option of using femoral access for a balloon pump. And then I only have 1 femoral access point rather than 2 if you're trying to undertake PCI at the same time as having a balloon pump running from the other point. So there is a role. It's usually confined to cases where we can't use the radial harvest, etc. But predominantly we will still take a radial access route as our first course for intervention.
Okay, thank you very much for sharing this exciting data and for adding evidence to the beneficial effects of transradial access. Thank you very much for watching.